Good morning, and welcome back to Good Samaritan Facebook Live. My name is Dr. Scott Stine. I'm a family physician here in Vincennes, Indiana, and Chief Medical Officer of Good Samaritan Physician Network. As with me, as always, Adam Thacker, who's our Chief Operating Officer of Good Samaritan Hospital. We'll be giving you our weekly update on COVID-19 and our community, talking about our usual topics, which is numbers, testing, vaccination, some of the things that have changed over the last week or so, which have been quite a few things, actually. And then giving you a general update on status in our community. Around 364 active cases within the community right now. The positivity rates that we talk about, probably some of the highest we've seen. Total positivity rate around 13, but then the unique individuals really is where things have taken off, almost 38% as far as unique positivity rate. And when we look across the state, that's some of the highest numbers that we have seen as far as statewide is concerned. And as we're in this third surge or third wave that we talk about, it has really affected our rural communities probably more than anything else because we really didn't see very many positive cases early in the disease process when we go back to the spring.
Right. A quick look at the state map on the dashboard. When I looked at it over the weekend, 16 of our counties were in red. We were a 92 county state. That put another 75 counties in orange and just one sole county in yellow and none in blue. And we've really seen that continuing to increase. And as you hear the numbers increasing, that score from 1 to 3, Knox County went from a 2 to a 2.5. Basically, everyone around us has the same or has progressed to 3. So we're seeing across the state an increased trend in cases, and certainly seeing more pressure in the hospital setting because as cases increase across the communities, even though we talk every week that the majority of cases people recover at home, 80+% recover at home and do not need additional medical attention. But that 20% that do, as the numbers go up, that 20%, those raw numbers go up, and it certainly puts pressure on our hospital systems. And we're seeing, I would say, what's the beginning of a Thanksgiving type of pickup of cases, and certainly there's not time for that to decrease before we get into the next holiday season. So something that we talk about commonly is as those times in the season come together for gatherings, we've got to be very thoughtful of that because we're looking at that surge on a surge where we have increased cases. And while we start the day out today, Good Samaritan, from a capacity standpoint and our hospital resources, we're in a good place. It's busy, but we're able to meet all of those demands. When you start to set one on top of the next as far as the number of cases in the community that lead to inpatient admissions, it puts pressure on our team and all of the resources in Southwest Indiana.
Yeah, and that kind of leads us a little bit to what has changed over the past few weeks, which is a change in the outpatient management of COVID-19, which has been fairly exciting. Going back about 3 weeks or so, we started to receive shipments of the antibody infusion, which initially was bamlanivimab, which was monoclonal antibody infusion, and then Regeneron, which was the product we heard about a couple of months ago when the president received that when he was ill with this. So the exciting thing about that product specifically is that is used and targeted specifically at the outpatient population. And as Adam was saying, the majority of the population that we see that gets this illness recovers in the ambulatory setting, basically with just supportive care. The exciting thing about this particular treatment is that this helps to manage some of those sicker patients and higher risk patients that are in the outpatient setting that don't require hospitalization, but that we're particularly worried about. And we target the populations that seem to be at the highest risk, which tend to be people over the age of 65 or people with chronic medical problems. Some of those chronic medical problems specifically that we look at are diabetes and chronic kidney disease and chronic lung disease, and even obesity as a significant risk factor for developing more complications as a result of the disease process. So starting about 3 weeks ago, we started administering this monoclonal antibody, and so far things have gone well.
Yeah, we've had 39 administrations of bamlanivimab to date. I believe when we looked at the numbers, only one of those individuals had progressed to needing hospitalized care. So while the jury's still out and those studies of data will continue to come through, what we've seen at Good Samaritan is that certainly it has worked, and that takes some pressure off of the inpatient side. That keeps folks from their illness worsening to where they need hospitalization. And it's a relatively simple in terms of how we look at medical care and infusion that happens over the course of an hour, and the antibodies help to neutralize the COVID proteins and the COVID virus itself. So it certainly is a positive note in what we're seeing with the being able to change care from all care was really being delivered once somebody got sick enough to be on inpatient, to now we're seeing some care modalities that can be delivered in an outpatient setting, keep folks out of the hospital, and keep that illness from growing and being able to recover at home or with minimal resources from the hospital.
And one of the key factors that we're trying to help everyone understand is it's very important to get identified as having the illness early on. So patients who are at risk, if you are over 65, if you are 55 or older, if you have any of these disease processes, specifically diabetes, kidney disease, obesity, chronic lung disease, immunosuppression, anything that would put you at a higher risk with regards to getting the illness and requiring hospitalization, we want you to get in, get to be seen by a provider, and get tested. Now, we have a whole variety of methods for doing that here locally. Certainly, seeing your primary care provider is your best resource to initially get in contact with them, do a little triage with nursing staff or with our triage line, get seen in a timely fashion, then determine whether or not this sounds like it's potentially COVID, get tested. We have those rapid tests available we've been using for the past several weeks, which gets you results within about 15 minutes or so, and then determine if you're a potential person who would benefit from the infusion. And then the other method that we have is going through our convenient care clinic. And there's two testing methods that we have out there. But when we talk about this infusion, it's important to realize that being seen by a provider and getting that point of care 15-minute test is important.
Yeah, that's really where it all starts, is that assessment by a provider, because the criteria that you spoke to, the monoclonal antibody treatments are ordered by a provider, nurse practitioner, physician assistant, physician who does that initial assessment to say, yes, you meet the criteria, because it's not only the criteria of risk factors with chronic diseases or age or weight, but it's also how long have you had symptoms and where are you at in that progress, because as these drugs were released, there's a specific window of patients that are appropriate and there's a specific window where they are not. So the providers make that assessment. The point of care tests are ordered by the provider once that assessment happens. You can go to convenient care asymptomatic patients that believe they were an exposure. The state has really pushed being able to get tested if you want to get tested. You still can go to our convenient care site and be tested as asymptomatic, but that will be a patient-requested test. The test will be performed, won't be assessed by a provider, and would not be eligible for treatment. But again, taking that path, you're asymptomatic anyways. Right. You're not going to be eligible for treatment if you are asymptomatic, and that's the test that is called PCR. It's the molecular test that is sent off, and that is taking in the 3-day range for results versus the point of care test. That's the 15-minute turnaround time.
And many people are asking kind of what's the utility of this antibody infusion? Essentially what we're doing is we're giving this antibody infusion, which is passive immunization to help fight the virus off, and preferably in the early first few days of the course of the illness is best. But this is somewhat of a bridge to getting us to vaccination and getting us to having enough of the population vaccinated that we stop the spread. So we talk each week a little bit about what the future of the vaccinations are and kind of what our transition is from where we are now to that vaccination process. Can you tell us a little bit about the timeline on that?
Yeah, the timeline continues to evolve every week, but what we know as of last Wednesday, and talking with our Indiana Department of Health representatives who have the link to the federal government and how things are moving through the vaccine process, is both the Pfizer and Moderna vaccines have been submitted to the FDA for emergency use authorization. Pfizer about a week ahead of where the Moderna product is. So really we're looking at, before the end of the year, we will have 2 vaccines that are approved for use in the United States. The Pfizer product actually was approved in the UK, and they're starting a mass vaccination administration this week. So that's obviously being watched very closely to see how that works, and there may be some tweaks that the United States makes to say this is what we need to do differently. What we expect is that next week we start to receive vaccine. We've talked about the phases before. Healthcare workers, frontline healthcare workers that are commonly interacting with COVID positive patients or have the risk of are wave 1 or phase 1. followed by phase 1B is your essential workers, and then that moves into your high-risk community members. So those would be similar patients that are eligible for the monoclonal antibody, age 60 and over, and looking at those high-risk conditions. It's always unfortunate that we have any deaths, and Knox County is reporting 27 deaths to date. On the website, we know that it's higher than that with comorbidities and everything that is going on in that reporting. But I looked at it this morning before we came online, and 85% of our deaths have been 60 years or older. So certainly as the vaccine comes out, I know we commonly get, you field and my field, and the safety questions. Are you going to get it? Is it safe? Is it rushed? Just to reiterate, the Operation Warp Speed that was put into place with kind of unlocking the COVID genetics to be able to create the vaccine was done with the amount of resources that allowed it to happen at a fast pace without cutting corners. So I feel confident that it has been done in a safe and effective way. Honestly, as a pharmacist, I feel confident in saying that this vaccine has probably been critiqued for safety more than any vaccine you've ever received, just because the focus in the last 9 months has been pretty singular focus, the COVID vaccine, and let's get to that point. So in the next couple of weeks, before the end of the year, we will start vaccinating healthcare workers. The goal is by the end of January that Knox, Davies, and Pike that we're responsible for as Good Samaritan have the opportunity to get vaccinated. And then as we move into the spring, starts to open up into the community. The latest prediction was by summer, the vaccine should be offered to all populations that are eligible. Pregnant women and children, it was not studied in yet. So that information is still yet to come out. I know there was some 60-minute and type of discussions over the weekend about, fall, going back to school, looking way ahead, would it be a required vaccine for students? And that is something that is still being evaluated, and we don't know the answer to that yet.
As Adam said, really the most important thing that we're looking at is stratifying that patient population that is high at risk and getting it to them as soon as possible in this process. And so all of us in primary care have been looking at those patients over the course of the past 6 months, and as we see them in follow-up in the office saying, hey, you're going to be in those early groups, you need to be somebody that receives that vaccine early on, because, again, looking at the patients that have the worst outcomes, we really want to target them early on. Those are the patients we're giving the monoclonal antibody infusion to. Those are the patients that we also want to get the vaccine for as early as possible. And as Adam said, from a safety standpoint, and even more importantly, an efficacy standpoint, this isn't just a good vaccine. This is an incredible vaccine looking at the efficacy. When we look at flu vaccine from years past, when we look at shingles vaccine from years past, things like that, that have success rates anywhere in the 40, 50, 80% range, to see 90+% efficacy in this vaccine is really tremendous. So we feel confident in it. We're excited that it's coming out. We just want to get it on the streets and get people vaccinated as quickly as possible.
And one thing to mention is just we've talked a lot about light at the end of the tunnel. We've got an outpatient treatment. We're looking at a vaccine. That immunity that covers the community, you've probably heard herd immunity, that a vaccine starts to create, that is not going to hit those level of percentages until after March. Yeah. So the holiday season, again, the winter season, are not times to say, well, the vaccine's around the corner, or healthcare has started getting the vaccine. I can be lax on the mask or the physical distancing or hand hygiene, all of those things. I mean, we're looking into spring before we're at a level that those things start to be considered to be lessened. And I think everybody just needs to see that as the reality. The vaccine is great news, but the next 2 months, at least 3 months, we don't anticipate any changes in what is expected of each of us from a community.
Yeah, and as we spoke about earlier, really this double hit with the holiday season is challenging because we saw rises after each of our other holidays, and that was with very small numbers within our community. Now that we're running in the 300 to 400 range as far as active cases, and this is not just unique to our local area, this is nationwide, we are seeing bigger spikes, higher spikes, more transmission, and so there's some very challenging decisions everybody has to make with regards to their holiday plans and what they're going to do. Just try to consider that whatever your inner circle of people, that is the safest people that you're likely not going to be transmitting with, and as soon as you start expanding those groups and bringing larger numbers of people together, that becomes very challenging. And when we look at that across the community as far as churches and how those gatherings are going, they have been strategizing to see how they can do that with larger numbers of services, with fewer people, and all of that has been in the works. So we ask everybody personally to do that with what you're doing with regards to your holiday plans. Visitation, as we kind of move into the next few weeks, any major changes that we're seeing with that?
Not at this time. We still are allowing one visitor with patients across the continuum of care, both inpatient and outpatient setting. Would reiterate from an outpatient setting, whether that is coming to our main campus or to one of our medical offices, that if a visitor is not needed for medical decision making or helping with mobility to get in and out of the office, we would ask that visitors aren't tagging along out of convenience, just because it's still a high recommendation that decreasing traffic allows us to stay more spaced out across any of our areas. Ultimately, I would also add into that all of our facilities have very diligent infection prevention practices. They're reviewed very closely pre-COVID, and this has just shined a brighter light on that. Putting off care because of concerns of safety outside of COVID can lead to some pretty dramatic effects down the road if chronic diseases continue to go undiagnosed, such as diabetes or congestive heart failure, those types of things. Once they get to a certain point, you can't reverse all of the damage that has been done. So if you need medical care, seek medical care. We have a number of ways to do that, from virtually, from with video visits, from telephone visits. Coming into any of our locations, we have safety protocols in place to keep you safe when you seek care. So this is not just a COVID hospital. COVID's not the only thing going on in our community. So make sure that you seek timely medical care regardless of the illness.
As Adam said, as we kind of limited those visitors that come in with patients, also important to understand that they need to be protected as well from the person they're bringing in to be seen. All too often we see family members who are coming in not masked, or who are waiting in cars with people to be tested unmasked. It's important to realize that is a lot of how the transmission occurs, and when we start looking at that, we're obviously masked all the time. Anybody that comes into the hospital or the offices are masked, but if you are bringing somebody in to be tested, specifically somebody who's been symptomatic, certainly please make sure that individual is masked. Please make sure that you're masked as well, because that helps to limit that spread within your own group and then within the community.
Our screening stations will be screening visitors, and masking is mandatory in all businesses, and certainly in the healthcare setting. If for some reason somebody cannot wear a mask, then face shields are an alternative, but not wearing any facial covering is not an alternative. You will not be allowed in the building. It's for the safety of our employees, of other visitors, of other patients, and that is where our priority goes.
Another big change that occurred was an announcement last week from the CDC that they had come up with other options with regards to quarantine and the timing of all that. Locally, we have reviewed those processes within our own system and also with our health officer, Dr. Stewart, and looked at what those recommendations are. And basically, the 14-day quarantine period is still considered to be the gold standard and the best thing to do. When we look at the CDC's recommendations on other potential options, we've also kind of accepted that if somebody has essential needs with regards to their workplace and so forth, that quarantine period can be brought down from 14 days down to 10 days. However, one of the recommendations that came out from them was that 14 is the best, 10 is okay, but you could potentially do 7 days of quarantine with a test at 5 days and then out at 7. And as we've reviewed that the data and the research behind that and what that would mean with regards to our resources and testing, we're really not going to follow that, just simply because we don't think it's safe at this point.
Right, and that really, we expect it to come out more formally this week, but that is the state recommendation, as well as that the 7-day quarantine period with a negative test, because of the resources that takes, because the data suggests that there's a range of acceptability for that, and when you're seeing increasing cases is not the time to move in that direction. It's really important that our symptomatic population, for reasons that we spoke about in identifying treatment or identifying potential need for inpatient care, that symptomatic patients can get timely treatment or timely testing to lead to that treatment. So we don't want to inundate the system with asymptomatic testing. 14-day. So when you look at the headlines of this CDC change, you can go and see all of the headlines from major publicity areas, and you don't see 14 days still recommended best practice. It goes to 7 days, 10 days, which is more eye-catching. But CDC language starts out with 14 days is best practice, and if local decisions can be made to keep a 14-day quarantine, then you should. So our group talked last week. 14 days is still recommended. 10 days asymptomatic without a test. If essential, need to get back to work. So your employer certainly plays a role in that. And that is asymptomatic. So it's really important that everyone understands that you can't have any symptoms for that 10 days to apply. Otherwise, if you're in exposure, let's say you get tested because you develop some symptoms, you test negative. It doesn't go to 7. You had symptoms. You are going to 14 days if you had symptoms, even if you test negative. So it's 14 or 10 for Knox County. The 7 days is not something that's supported by health officials, by Good Samaritan, by elected officials that were part of that discussion. It just doesn't make sense when we're seeing a report of the highest positivity rates that we have seen to date.
And we will continue to look at that on a weekly basis to see, number one, what our positivity rates are, what our numbers are within the community, the circumstances surrounding the holidays. All of that is going to be something that plays into those decisions. But when the recommendation came out, we critically looked at that and felt like, given our local circumstances, it's really best to stick with the 14 days if at all possible, and then 10 days based on some options. You talk a little bit about programs we have coming up with the hospital in the near future.
Yeah, this evening, 6:30, there is a Park and Pray event. We'll have that at 2 of our parking lots here on the main campus. There will be signage to help direct to 6th Street parking or Memorial parking. WZDM will be airing that at 92.1, and something that we would love to see community involvement with. Our healthcare team is on the front lines every day, taking care of not only COVID patients, but patients across a 10-county region that we provide care for. And certainly there's a lot of stress. Folks are tired as we move into this season of seeing the increase in cases, and would love to see a large showing of community support at the Park and Pray event. That, again, is this evening at 6:30. WZDM 92.1 will be airing that, and we'll have signage at the campus to help with where to park, so we don't interrupt the flow of care that's going on within the building.
Okay, thank you. We have any questions on the phones today?
Okay. And just another reminder about that. It's important for people to stay inside of their vehicles during that event. We don't want big groups of people outside of their vehicles gathering, so we hope to see a lot of people come out for that. Now to some questions. Someone asked, if a patient has COVID pneumonia, but they are 10 days after their positive result, are they still contagious? How long are they contagious?
So a lot of that has to do with the severity of the illness. You've heard us talk about in past that there is the mild to moderate illness and then the more severe hospitalized illness. And the times of isolation are greater for the more severe illness. And so really we look at those kind of individually. The two general groups are 10 days versus 20 days. And the majority of patients that we see and encounter who have had the illness have a 10-day isolation period. That's from onset of symptoms. And then, of course, they need to be symptom-free, fever-free. And that number has been kind of a moving target. But I still tell people 48 hours in terms of until you are symptom-free, until you're released out of your isolation. So if you still have symptoms on day 9 or you have fever on day 9, you're not out at day 10. You need to go at least 48 hours symptom-free. The more severely ill patients, the target number is really 20 days. However, that's also variable, because if they are continuing to have symptoms, if they still have cough, if they still have fever, if they still feel bad, then that period of time needs to be a bit longer also. We don't necessarily always get chest x-rays on these patients unless they are more severely ill, unless we're considering hospitalization, or unless we're concerned that maybe they have a secondary pneumonia, like a bacterial pneumonia that forms in addition to the viral infection. And so each of those are things that your providers can discuss with you, but generally it's 10 days for mild to moderate illness, and then it's 20 days for more severe or hospitalized illness.
Someone asked about the COVID vaccine. Is it a one-time shot, or do you have to have the shot once a year like the flu shot?
Oh, I thought that question was going to be regarding, is it a one-shot or two-shot vaccine? So I'll kind of answer that in two parts. The first two vaccines that are going to be approved before the end of the year, expected this week on Pfizer to be approved, and then we'll start moving forward, are a 2-shot regimen, meaning that you get 1 shot on what would be day 0, and then 21 to 28 days, depending on which vaccine we're talking about, there is a second shot, and that second shot is really important. So as we move into the community, getting 1 shot is not, well, that's probably 70% good, I'm just not going to get the second one. All of the studies, all of the information is built on getting both shots, so we really got to adhere to that. As far as, is this a one and done forever versus is this an annual event such as an influenza shot? We don't know yet. There are so many factors within that. One is going to be studying the efficacy of the vaccine itself and how long immunity is created for. And the second is the virus itself. And as we know, viruses can mutate and change. And the technology being utilized to create these initial vaccines is different than has been used before with it at a genetic RNA level. The hope is that this is a one-time event with the 2 shots, that you have lifelong immunity, but there are no studies that have been able to take it out that far because we didn't know about this until early in 2020. So that remains to be seen. We're hopeful that that will be the case, but it very well could end up being an annual event, or at least more than once, and then produce those immunities.
If a person is going through cancer treatments, can they get the vaccine?
Yes, absolutely. And not only do we look at that in terms of the vaccine, but also the antibody infusion. And we've had a number of patients over the course of the past few weeks who were undergoing cancer therapy or were considered to be immunosuppressed that we have used the antibody infusion on. So the antibody infusion, the monoclonal antibody infusion, is really kind of a bridge to get people to vaccination. But absolutely, those patients are going to be in one of the highest risk groups in terms of who should be getting the vaccine first. So absolutely, they would be candidates for the vaccine within that, essentially the end of that second group, the 1B group.
And with the vaccine, part of the reason why that would be appropriate, these vaccines do not contain a live virus. You cannot get the COVID virus from these vaccines. It's not just the first 2. That's really how vaccines are created in moving forward, is that the technology does not use a live virus for these vaccines. So the other question that comes up with that is, I get the vaccine, will I test positive for COVID? So on a viral test, you would not test positive for COVID. On an antibody test, the idea would be that you would.
Certainly,
I mean, that's what we want to happen, is that you would produce those antibodies.
Okay, that looks like all the questions we have today.
Very good. Any other things today, Adam?
No, I don't believe so.
Okay. Thank you all for joining us, and we'll be with you again in a week.